Hello, my name is Ronna Moore, speaking to you from the lands of the Kulin Nation in Melbourne, Australia. Thank you to AMTA and the Massage Therapy Foundation for the opportunity to bring you an encore presentation of a poster related to a research project which asks the question, how is massage conceptualised and operationalised in palliative care? To find answers, we conducted a scoping review applying the methodology outlined here. Relevant databases and sites for peer-reviewed and grey literature were identified, and we employed Confidence to assist with collation and screening of the included materials. 31 documents remained after screening, featuring a range of study types, populations and settings across 6 countries. From these, we then applied the Donabedian SPO healthcare framework to categorise and examine data capable of addressing our research question. In practice, this meant scanning the literature for any information related to these features, which also means we have a lot of data. At a fundamental level, Donabedian asserted that the philosophy, values or rationale underpinning a health service were pivotal to its success or effectiveness, and we use this notion to identify facilitators of massage services to answer the why provide massage question. The primary facilitator we identified was evidence of benefit, ahead of other factors such as alignment with the holistic goals of palliative care. We also looked at data related to barriers or the why not of massage provision, and lack of evidence was the most reported barrier. The question of barriers will be revisited later in this presentation, but for now we're looking at another structural component relating to the identity of the provider who is doing the massage. Of the documents that provided this information, most reported licensed or trained massage therapists, and amongst those, just on half were reported as having additional or specialist training, with a small number identifying oncology massage or hospital-based training. Other characteristics reported were related to scope, for example. Now, turning attention to processes, we looked at referral practices. The main referral indicators reported are perhaps not surprising, but what is notable is the broad range of indicators and reported effects, because this really highlights the holistic application and wider scope of massage therapy practice. Finally, we look at the outcomes part of the SPO framework. Use of formal assessment instruments such as numerical rating scales with pre-selected symptoms were reported in the randomised controlled trials and other research papers included in the review, as might be expected. However, in the studies reporting on existing massage services, use of tools for routine assessment of evaluation of services was low. So what do our findings tell us overall? They confirm that there is a presence of massage in palliative care settings, as there has been in some form for a very long time. A key finding of this review was that studies conducted more recently were more likely to report professional massage therapists as providers rather than nurses, physical therapists or volunteers. Also indicated were higher levels of participation of massage therapists within multidisciplinary teams. This might suggest that there is a movement towards massage therapy being conceptualised as a distinct discipline with a defined scope of practice embedded within the palliative care environment. However, our findings identify wide variability, inconsistency or absence of essential components of service delivery as identified here. Contextual factors will always lead to differences in how services are locally operationalised. However, in disciplines such as nursing or physical therapy, there is an expectation or degree of consistency with respect to a discipline's scope of practice, practitioner competencies, and clarity about how the discipline fits within the model of care. That kind of consistency is not currently being demonstrated in massage therapy in palliative care practice or in the literature, creating, we suggest, barriers to further integration of massage therapy in palliative care settings. So the implications drawn from this review are directed towards those barriers. In conclusion, this review describes a discipline, or at least a subset of a discipline, that is in a formative stage of development. There is work to be done to ensure people living with life-limiting illness have access to massage therapy delivered in a manner that will optimise its potential benefits, and this can only be achieved through continued efforts by and collaboration with all stakeholders. Thank you for your time.